There we go.
All right. Okay, all right. Welcome, everybody. So this is an academic half-day talk on HIV pre-exposure prophylaxis and post-exposure prophylaxis. I know depending on which clinic you guys go to, some of you may have already some experience screening and prescribing pre-exposure prophylaxis or PrEP for patients. Some of you have not. So we're going to go ahead and just kind of start with just some background, just so that we're on the same page. And please feel free to let me know if you have any questions during this. All right. So taking a step back, before we talk about PrEP, just a quick overview. HIV epidemic, an ongoing epidemic, affects everyone globally with various varying, incidence prevalence of worldwide, as you can see on this map. And this map is back from 2016, but it's still pretty accurate to this day. And the good news, though, is if we look at incidence over time, over the last couple of decades, it has started to taper off just a little bit, downtrending, and a lot of that for both new incidents of infection and HIV-related deaths. And a big part of that in the overall goal of trying to end the HIV epidemic is prevention, trying to prevent new infections of HIV. And that's really where PrEP has really changed the game and has become a major, extremely useful tool on this front to try to combat the HIV epidemic. So that's why we're going to talk about that. Just a little bit more data, 2018, according to CDC, over 1 million persons living with HIV in the US, but an overall decrease of about 7% in incidence from 2014 to 2018. And there are some disproportionately affected populations, which we'll go into in more detail following slide. So if we look at the United States, you can kind of see how a lot of the southern states, and then you add New York, have particularly high rates of new HIV diagnoses. So definitely something to keep in mind. When we break that down into age range, young adult population, 25 to 34, definitely has the highest rate of diagnoses amongst other age groups. However, don't forget that even if, say, someone is a little bit older, greater than 55 years, the risk is not zero. HIV infections affect all age groups. But when you're trying to screen patients for high risk factors, age is one factor to keep in mind. As well as sexual contact. So male to male sexual contact, IV intravenous drug use, definitely risk factors. As you can see, MSM contact as being the highest percentage population group attributed to new infections. And this is just talking about the United States. And besides just sexual contact, race, ethnicity as well, as you can see clearly on this chart. So when we're going to go through the following slides regarding PrEP, it's a good idea to, I think, keep in mind for our patient population, the patients we're seeing outpatient, are we really, the patients that are requesting PrEP and the ones that we're offering it to, are we really targeting or are we missing particular populations that could really benefit? So let's dive right into PrEP. So what is PrEP? So this may be familiar to you if you've already used it, prescribed it for a patient, but to start at the beginning, so tenofovir disoproxil fumarate, or TDF for short, plus emtricitabine, or FTC for short, is the co-formulation in Truvada, which is the first approved FDA agent back in 2012 for PrEP. It's a fixed dose, 300 milligrams plus 200 milligrams, and it's in a single tablet. It's like a blue pill that you can see on the upper right side. It's an NRTI combo, and it's pretty easy to take one tablet once a day with or without food. It's metabolized intracellularly, excreted renally, which is important to keep in mind. Some patients are particularly concerned about renal function, so it is not recommended if creatinine clearance is less than 60 ml per minute. And we'll talk about that a little bit in more depth soon. Some common adverse effects that are reported for the TDF-FTC combo. So there is some decreased bone mineral density seen in studies. This effect does seem to plateau after 6 months of taking the medication, and it is seen to be reversible after discontinuing medication. And there seems to be no change in actual fracture risk. However, unknown long-term outcomes. So some patients are they'll ask me, is TDF-FTC safe for me because, what if I'm, gonna have weak bones and break a bone or something? So I try to reassure them that there is no change in fracture risk according to the data that we can tell so far. Nausea, diarrhea, dyspepsia, that does happen in some patients, I think the minority, but usually it tends to improve once they take it for a couple of days to weeks. And I've had some patients tell me that once they take it with food, it's a little bit more tolerable. And renal toxicity. So this comes up a lot more, I think, recently, because some patients will say, oh, I saw in the news, like Gilead is being sued, or, there's all these websites for lawsuits against this medication because of renal toxicity. So the data shows that there is a absolute risk of 0.1% of serum creatinine elevation, but it wasn't associated with grade 3 or higher creatinine elevation. So that's like at least 2 times upper limit of normal. So by and large, the risk is actually quite low for renal dysfunction, but it can happen. But I do tell them that it's very uncommon. And even if it does happen, the majority of cases, it doesn't actually end up altering management. And there has been, I think, a couple case reports on Fanconi syndrome, but it very rare. And when the case reports, those patients were also taking other drugs that could have been associated with Fanconi syndrome. So it's not entirely clear if TDF is the actual cause of it or not, but we still caution it. Another important thing to keep in mind is that tenofovir does suppress hepatitis B. So if you have patients that do have chronic Hep B or being diagnosed with Hep B, that's something to keep in mind, because you don't want to discontinue it and risk reactivation. In 2019, so just a couple of years ago, a newer formulation called tenofovir alafenamide, co-formulated with emtricitabine, a brand name Descovy, was approved by the FDA for PrEP. It's important to keep in mind that this is not for all patient populations, because based on the studies that were involved in the trials for Descovy, it's only been approved for MSM and transgender women. It's pretty new, so there's no generic available, but it's the same class and administered the exact same as Truvada. So for patients that are switching between two, they take the administrations the same. It's a smaller pill, which some patients like, and there's less association with renal and bone toxicity. And because of that, you do have a lower threshold to be okay for your renal function. So as long as the creatinine clearance is 30, it's safe to use Descovy. So if you have patients with some renal impairment and creatinine clearance is below 60, but above 30, you can use Descovy instead. So adverse effects, this kind of came out after the medication was widely available. So a lot of patients are, and I think providers are unaware of this, but it's starting to get a little bit more traction in weight gain and dyslipidemia as being side effects of this medication. We need more data regarding long-term impacts because it's still pretty new, but it's a good thing to keep in mind because some patients think, oh, this is like a cleaner or better version of Truvada with no side effects, and that's not true. Keep in mind it's not approved for PrEP in women or transgender men, but it still has, the tenofovir alafenamide still has activity against Hep B. Timing before optimal efficacy. So Truvada or Descovy, you do have to take it for 7 days before assuming maximal protection for receptive anal intercourse, and 21 days Truvada before receptive vaginal intercourse. This is due to time until you reach optimal drug penetrance in different tissues. So while patients are starting, if you're starting patients on these medications, we just want to reinforce the importance of protection and safer sex practices, because the first day they take the drug, they can't assume that they are maximally protected by the medication. So just some evidence for PrEP. We won't spend a lot of time on this, but just so if you're interested, you can read more, look up these studies because they're pretty interesting. But so back in 2008, there was a phase 3 double-blinded RCT in Kenya and Uganda for serodiscordant heterosexual couples. So that means that it's an HIV negative patient with an HIV positive partner. And they were not enrolled if the HIV positive partner was actually taking ART or antiretroviral therapy. And so patients that there was a patients in Truvada arm, there was a 75% risk reduction of acquiring HIV infection. And when they tried to measure serum levels of tenofovir in the plasma as a marker of adherence to the medication, those that remained HIV negative, 82% had medication detectable in plasma. So adherence definitely is attributed to greater efficacy. Another study, IPREC, so this was done in high-risk MSM and transgender females who have sex with men. Very similar results overall. So the bottom line really is detectable drug levels had a relative risk reduction 92%. And so really adherence, and the more you take the medication, the better your protection against acquiring HIV infection. So again, not going to go into full details of these studies, but feel free to look these up if you're interested. FemPrep, this was a phase 3 double-blind RCT, and this targeted young adults age 18 to 35. And big thing to note here, which kind of hammers the point home, this study was discontinued due to lack of efficacy, but there was it was in the context of very low adherence to study drug. So again, the point being that adherence is really a major key of PrEP when you're counseling patients. So that calls into question, like, so how often do you have to take this medication? So is it daily for everybody? What about patients that can't take don't want to take the medication daily? So there was a study called IPERGAY done in France, I believe. Yes, done in France. And it's called on-demand or 211 PrEP. And some patients will ask you about this, about on-demand PrEP. So basically it's sexually event-driven Truvada. And as you can see from the figure, the instruction was prior to 24 hours before sexual activity, you take 2 pills at the same time. And then you take 1 pill every 24 hours after that until you finished 2 doses after your sexual encounter. So if you only had 1 sexual encounter, you would in total take 4 pills. If you continue to have high-risk sexual encounters during your 2-1-1 dosing, then you keep on taking 1 pill once a day until you finished 2 doses after your last sexual encounter. So this trial only studied Truvada because Descovy wasn't really available yet. So this did show a relative risk reduction of 86%. And so it has been approved by the World Health Organization as a strategy to help patients reduce the risk of HIV if they infrequently have high-risk sexual encounters and don't want to take a daily medication. There definitely needs to be more studies on this for more populations. So keep in mind, this is not a strategy that's approved by the FDA. So it's kind of an off-label use. So the New York City Department of Health does allow does recognize on-demand dosing or 2-1-1 dosing as a strategy for patients, but it's kind of, again, it's like an off-label use. And requires careful counseling because it can be a little confusing for patients because you don't want them to mess up the 2-1-1 dosing strategy. And not appropriate for chronic Hep B because you don't want someone on and off and on and off of tenofovir if they have Hep B. Okay, so who should be offered PrEP? Now that we reviewed basically the medication and a little bit of the evidence behind it. So who should we really target for this medication? So for this, let's go to a vignette. So a 33-year-old cisgender female patient presents for follow-up visit. She was treated for gonorrhea 6 weeks ago, and she's had no sexual encounters since then. She does have a prior history of IV heroin use, but last use was 9 months ago. And she's now following with an outpatient addiction treatment program, doing great. She has begun dating somebody and shared that he is HIV positive, but has been undetectable for 2 years. But they're not in a monogamous closed relationship, so she is interested in reducing her risk of HIV. So just given this, which of the following, A, B, or C, is the patient's strongest indication for PrEP? Not her only indication, but of the three. Any thoughts?
So Raphael is writing in the chat that he thinks it's A. I don't know if anyone else wants to give their opinion as well.
Okay, yeah, so I'll go ahead. That's good. So A is correct. So a bacterial STI that was recently diagnosed in a patient. So it's within the last 6 months. That is a clear indication for PrEP, and that's because patients that have had a bacterial STI within the last 6 months are considered at a higher risk of acquiring HIV. Because if we look at data of new HIV diagnoses, there definitely is an association of last 6 months diagnosis of bacterial STI like gonorrhea and syphilis for all patients, and chlamydia if you include MSM. Prior history of IV substance use would not really, as long as she's not using, if her last use was 9 months ago, then that wouldn't affect her risk. And if her partner has HIV but is consistently undetectable, then he does not have a risk of transmission through sexual means for HIV infection. Okay, so I get a lot of questions about, so is there like a list of guidelines or criteria for PrEP? And it can be a little tricky because there is definitely variation between guidelines, but there are some common factors. So the USPSTF, their considerations to offer PrEP are bacterial STI in the last 6 months, shared needle use, transactional sex, so that's sex in exchange for money, drugs, housing, or other things, serodiscordance in their partner, MSM with inconsistent condom use during anal sex, heterosexual men and women with inconsistent condom use with partners of unknown HIV status, and transgender women. The World Health Organization, bit of a short list. It's if you live in an area high HIV prevalence and have unprotected sex with more than one partner or bacterial STI, or needed to take post-exposure prophylaxis in the last 6 months. The CDC, they actually just released a brand new update that I just barely managed to edit into the slide. So their 2021 update really kind of lowers the threshold to indicate patients for PrEP, and really kind of made it a lot easier for patients to have access to PrEP according to their guidelines. So for sexual acquisition of HIV, they propose this algorithm. So if any anal or vaginal sex in the last 6 months, if yes, if they have an HIV positive partner that is not consistently undetectable, then they're indicated for PrEP. If their sexual partners are of unknown HIV status and they're not consistently using condoms, then they're indicated for PrEP. And if they had a bacterial STI in the last 6 months, then generally, yes, they're indicated for PrEP. But even if they say no at any one of these branches, you can still discuss PrEP and prescribe it if requested. So that means that per the CDC, they don't require a patient to necessarily disclose their high risk factor. If a patient requests PrEP, like they're making their decision themselves that they feel like they would benefit from it, then you can offer it to them and prescribe them PrEP. This was released alongside a new grade 3B statement that we should inform all sexually active adults and adolescents that PrEP is available and can protect them from getting HIV. And this is to help, and they're thinking that talking about PrEP can help patients overcome stigma or embarrassment that they may not want to necessarily disclose to a healthcare provider about behaviors that put them at risk for getting HIV. And so again, this really kind of, I think, loosens the or lowers the barrier. So and takes into account that, you know, sometimes patients are at high risk, but if they don't state it, they may not be aware that they have access to something, another thing in their toolkit to help protect themselves. So it's just something to keep in mind. So I do make sure that PrEP is something that all patients are aware of, and it helps, you know, in our clinic, we have like signage to kind of help advertise it, and more patients are starting to hear about it. So, so that's been reflected in the new CDC 2021 guideline. Okay, so let's say, so same vignette, I didn't change the background. So for this patient, the 33-year-old cisgender female. So we do know she's had a gonorrhea infection 6 weeks ago, which puts her at high risk. So which of the following medications can we use for PrEP for this patient? A, tenofovir alafenamide and trocytamine, which is Descovy, or B, Truvada, or C, either A or B can be used. Any thoughts?
So it seems like people are mostly saying B.
Yeah, so B. So correct, right. So remember that Truvada is the only one that will be approved for this patient because she's a cisgender female patient, and Descovy is not approved for her. So that's something to just keep in mind, because sometimes we'll have patients in clinic, if they're cisgender female, they'll say, oh, I heard Descovy is new. Can I switch it over? The medication sounds really similar. And you just want to be careful because it's not been studied in that population, that it's not yet been approved. So you would have to stick with Truvada. Okay, great. All right, so after discussing risks and benefits of PrEP, she does agree to get some initial labs done and proceed with initiating PrEP. And lab results are as follows. So her HIV and gonorrhea syphilis screening is all negative. She has a good creatinine clearance of 90 mLs per minute. UA is normal. Hep A antibody total is negative, and her Hep B surface antigen antibody and core antibody are positive, and her Hep C antibody is negative. So, I mean, this definitely would obviously warrant further lab work to kind of clarify a few things. But if she would like PrEP to be started now, and given what you know so far, which dosing frequency of Truvada, which is the only approved medication for her, would be most appropriate? So would she be eligible for on-demand PrEP, aka 2-1-1 dosing, only around episode of sexual activity, or take PrEP within 72 hours after sexual activity, or C, once daily dosing?
Seems like people are saying C for the most part.
Right, exactly. So, so the answer is C, right? So she's not eligible for on-demand PrEP because there is a question, does she have chronic Hep B? And taking PrEP within 72 hours doesn't apply to PrEP. But we'll revisit that time window when we talk about PEP. So, I mean, these are pretty easy, straightforward questions, but that's because PrEP is really not too complicated actually to start for patients. It is oftentimes their risk factors are pretty straightforward, and starting PrEP is not too difficult. So in the outpatient primary care setting, I think we do want to get to a point where it's commonplace to initiate patients on PrEP if they're indicated for or if they request it. And by and large, it's a safe medication to take. Whoops. Okay. So I know a lot of info on this slide. I won't go into details, but just for minimum routine lab monitoring for patients on PrEP. So at your initial screening baseline visit, you do want your HIV test, of course, and you want their baseline creatinine clearance and all of their STIs checked. One thing that is a newer recommendation is if they're going to be on Descovy, which is the newer tenofovir alafenamide formulation, because of that association with dyslipidemia and weight gain, you do want to get a baseline lipid panel, and you will repeat the lipid panel in 1 year just to see if they've developed a worsening lipid profile and monitor their weight. And of course, you want to get a baseline Hep B serology if you don't already know their Hep B status. And me personally, I get Hep C screening as well in all patients, and all adults should be screened for Hep C at least once anyway. And every 3 months, you do want to recheck their STIs, bacterial STIs, and HIV screening. The newest guidelines do recommend patients to be screened with an HIV RNA test every 3 months. I think the CDC just dropped that recommendation just last month. So most clinics were still actually just using 4th generation screening, but the concern was, are we missing underlying or occult HIV infections if we're not getting RNA testing? So if you have the means, then you certainly can do RNA testing. But if you're out in the Ryan clinics, we're just doing HIV 4th generation testing for now until further notice. And creatinine clearance, you don't have to actually check it every 3 months. I know in the Ryan Center is our protocol, we do check every 3 months, but at minimum, you can check it just every 6 months, as long as every 6 months if their age is greater than 50 and or their creatinine clearance was below 90 when they started, or just annually if they're below age 50 and the creatinine clearance was more than 90. All right. So kind of hot off the press, several weeks ago on December 20th, the FDA just approved Apretude, which is cabotegravir. So this is the first injection RX for PrEP. And it's a long-acting injectable medication. It's really new. I've not used it personally myself on any patients yet. So I don't have any experience on the medication, but it's definitely something to just be aware of, because I imagine some patients will definitely feel like this would be a great option for them as an alternative to oral medication. Things to keep in mind is that cabotegravir has no activity against Hep B, but on a good side, there's no dose adjustments needed for renal or hepatic impairment, so there's no need to monitor creatinine clearance for these patients, and all you need to do is screen for HIV, syphilis, gonorrhea, and chlamydia. Your initial HIV test should definitely be an RNA viral load test, though, to ensure that they're definitely not HIV positive, because once you inject this medication, it's in their system and you can't just, take it out. So from what I can glean, there's an optional 30-day oral RX version that you can start patients on, and then they do 2 injections separated 1 month apart, and then they just come back for injections every 2 months moving forward. The 30-day oral RX is optional because all the trials on that included an oral lead-in found no significant side effects for these patients. So they actually decided to make the 30-day oral lead-in as optional. Although it was noted that most patients preferred it just kind of as reflection greater apprehension of just starting a new medication that's going to be injected. So definitely something to look up on your own time for more details. This is something I still have to kind of read up more on all the studies before I implement it for my patients, but definitely some exciting news regarding PrEP. Okay, so let's move on to post-exposure prophylaxis. So occupational HIV exposure risk for PEP. So all clinics and institutions should have policies for occupational HIV exposures and what to do. And the risk of infection does depend on your type of exposure. Excuse me. So percutaneous, so the high risk exposures will be percutaneous injuries or exposed mucosal surface or non-intact skin that's been exposed to blood, semen, vaginal secretions, or body fluids contaminated with blood. Intact skin is not considered an exposure, and agents that are not considered infectious are saliva, sweat, tears, vomit, nasal secretions, feces, urine. They will not have any HIV virus in them, unless obviously they're grossly contaminated with blood. So like I said in the last slide, I mean, the specific workplace policies for occupational exposures do vary site to site. So Mount Sinai, obviously we have our own, but in general, you cleanse soap and water, antiseptic, and flush mucosal surfaces, and you want to determine the HIV status of the source. Obviously, if they're HIV negative, the source is negative, then it's not a non-exposure. PEP is not indicated. If unknown, if the source status is unknown, if possible, you can obtain testing, then do so. But since testing does take some time to get results, you won't delay PEP. You would just initiate PEP if it was a potentially high risk exposure, because you can always discontinue PEP. And if the patient is positive, then you do start PEP. One thing to keep in mind that's different from non-occupational exposures is PEP is still recommended, even if the source is HIV positive and suppressed with an undetectable viral load. So for instance, if this is like a percutaneous exposure and from a patient who's HIV positive, even if they're undetectable, you can still be offered to indicate for PEP. So to start PEP, you must ideally start it within 72 hours, even better at ASAP, so within 2 hours. And the duration of treatment is 28 days officially. I've had some patients ask me, if they could discontinue it early. And the answer is really technically no. The duration is 28 days. However, 28 days is kind of an arbitrary duration that was selected because there's no real studies of like, oh, let's try it for just 7 days and see what happens. So we do say a full 28 days, although I think anecdotally, taking it for at least 2 weeks has not, and then stopping has not resulted in any new incidents of infection as far as I'm aware of. Descovy is not recommended for PEP as a first-line recommended agent. So because Descovy has not been studied for PEP. So if a patient's kidney function does prevent their use of Truvada, you may want to consider consulting with a specialist. For Truvada, you can alter dosing for renal dosing if necessary. But if there is like a major contraindication to Truvada, on a case-by-case basis, you may be able to use Descovy. But major concern is that Descovy does not have the same tissue penetrance and mucosal surfaces as Truvada does. So that's why Descovy is not ideally recommended for PEP in most cases. So preferred regimens for PEP would be Truvada plus dolutegravir, which is an integrase inhibitor, or Truvada plus raltegravir, which is another integrase inhibitor. These two regimens have been used for a very long time for PEP. They're very well tolerated, very highly efficacious. They have a high barrier to HIV resistance and very few drug-to-drug interactions. So that's why they're preferred. For alternatives, there are some alternatives available, but most of the time, Truvada and dolutegravir, Truvada, raltegravir are used and sufficient. Okay. So for lab monitoring, you do want HIV for fourth generation testing at baseline, and then repeat HIV testing at regular intervals. We do not recommend checking HIV testing while they're still taking the PEP during those 28 days, because if they're taking the PEP regimen, even if they have an HIV infection, you are suppressing it. So you don't want to, so if they did acquire an HIV infection and then your HIV testing on PEP comes back negative because it was being suppressed by a medication, you don't want patients to misunderstand that result and then just stop the PEP early. So we recommend the next HIV screen to be done after they finish their PEP regimen. And you would just want to check their other routine labs at baseline every 2 weeks, at 2-week mark. Definitely counsel patients on symptoms of acute HIV infection. So it'll be like fevers, rash, it kind of like viral syndrome symptoms, and GI symptoms like diarrhea, abdominal pain. We would recommend precautions for 12 weeks to prevent possible secondary transmission. For non-occupational post-exposure prophylaxis, most things are pretty similar. You do have to obtain like appropriate thorough sexual history and risk factor assessment for the patient to determine if PEP is needed for the patient. A high risk, for example, a high risk exposure will be sexual exposure without barrier protection in the sources, either HIV positive or just unknown status, or a percutaneous exposure to blood or potentially contaminated fluids. In general, not high risk quote unquote exposures will be if there was appropriate barrier protection, or the patient themselves is on PrEP and taking it appropriately, or the source is HIV positive, but they have a consistently undetectable viral load for a sexual if the route of exposure was sexual. And this is because patients that have a consistently undetectable viral load are not able to transmit HIV through sexual means. And they would have to be consistently undetectable for at least 6 months. But the medication choices and the screening regimen is the same as with PEP. Okay, so that was my last slide. I want to leave like 10, 15 minutes for questions or discussions and stuff, because I know it's a lot of info. So please, any questions?
Hi, I had a question. I don't know if you can hear me well.
Yes, I can hear you.
Hi. Okay, perfect. So you were saying for post-exposure prophylaxis, you don't care about the like viral load necessarily of the partner, but for pre-exposure, that's not as much of an indication for starting PrEP. Is that true? Or is it like you're still like in that question that you gave us, it wasn't the indication, but would it be an indication in general for pre-exposure if somebody asked?
Yeah, you mean like if a patient says, hey, my partner is consistently undetectable, am I still indicated for PrEP or not? Is that the question?
Yeah, sorry, I hadn't seen it on the slides maybe as well. But
no,
I know with the
absolutely.
post-exposure.
Yeah, so what I counsel patients is if a patient says, I am sexually active with an HIV positive partner, but they are consistently undetectable, and they don't have any other partners, like if they're in a monogamous relationship, then I do counsel them that if the partner is undetectable, they're untransmittable. So if the only means of possible exposure is sexual transmission, and this does not include sharing needle use, but just for sexual transmission, then their partner cannot transmit HIV to them. So if the partner is inconsistently undetectable, like they're not undetectable for at least 6 months continuously, then transmission is definitely possible. So then I would be more likely to go ahead and prescribe them PrEP if the patient wants it. But for most of my patients who have a partner that's consistently undetectable, usually they don't feel the need to be on PrEP. But if they do request it, then I do still prescribe it, because sometimes patients don't necessarily disclose, all the risk factors. Sometimes they may have other sexual partners or other behaviors that could increase their risk, but they just don't feel comfortable disclosing it right away. So they'll say, oh, could I still have PrEP anyway? And then I go ahead and get the labs and I prescribe it for them. And then sometimes after a couple of visits, they'll say, oh, it's because of this or that. Does that help a little bit?
Yeah, no, absolutely. Thank you for going into that.
Sure.
Hey,
Any other
Dr.
questions?
Ian. I had a question as well. I got to think about how to word this. So for like post-exposure prophylaxis, or for people wanting to take PrEP, if you were to like look at the transmission rates of individuals, whether it be men who have sex with men or men who have sex with women, et cetera, the transmission rates, or like the likelihood, is like a very low percentage of like HIV being transmissible, like during unprotected sex. Is that correct?
Yeah. So are you talking about, oh, like each episode of
Yeah,
sexual
so
activity?
each episode there's like a low percentage. How do you take that into account with HIV viral loads? Does that percentage change, or is that percentage just basically the standard for whoever is HIV positive? How do you
Yeah, so yeah, because I know like online, like there are like charts with like different ratios, right? Like risk ratios. Is that what you're referring to?
Yeah, exactly.
Yeah, so that's assuming that the patient does not have a consistently undetectable viral load. So so for sexual transmission, if the patient, if the source is HIV positive, but with a consistently undetectable viral load for at least 6 months, their risk essentially goes down to negligible, or basically zero. And so those ratios are not assuming that the patient is undetectable. So if you don't know the viral load or history of their whether they're undetectable or not, then I would assume I would use those risk ratios as my reference point. But if they are undetectable, then those risks are lower. And those ratios are, yeah, I mean, they're kind of averages. So, I mean, different things also increase your risks. So for instance, someone who, if you have a patient that, for instance, is acutely viremic, they recently acquired an HIV infection, they're presenting with fever, with chills, with a rash, and they, due to a recent HIV infection, their viral load can be in the millions, and they are highly contagious. So the risk goes way up. But yeah, if they're undetectable, then it goes way down.
Got it. Thank you.